Thank you, Raman, and thanks to the Mellinkoff Symposium organizers for allowing me to speak. And I'm a medical oncologist, so obviously this will come from our angle about how precision medicine has already changed, and to some extent how it continues to change how we treat patients that have GI tract malignancies. So over the last nearly 100 and something years, as you could see, our understanding of the cancer genome has changed dramatically from the early days in which it was clear that there were direct genetic implications into etiology and pathogenesis of cancer. But this has all accelerated a lot over the last 20 years or so, where the full sequence of the human cancer genome has been sequenced in virtually every malignancy out there, and a decent understanding of which genes are at least abnormally mutated or activated in the majority of cancers has been very well described. This has coincided, of course, with industrial development of drugs that can target specific genetic mutations, which has, of course, changed how we treat cancer nowadays. So the questions, and there are many in this evolving field of how this changes how we treat cancer, is, and I just listed some of these here that are relevant, but who do we test for these mutational studies? What kind of tissue is the best way to test to answer these questions? Is what's called liquid biopsy, which is basically a blood test, sufficient and able to replace classical tumor-based tissue testing? Who's going to pay for this? Because it does cost some money, and it's not uniformly approved or reimbursed by all insurance companies. And what are the meanings of some of these mutations? And EGFR, which is the classic mutation in lung cancer, is been around for like 20 years, but then there's all these other ones that are emerging now. And what do they mean? Are they clinically relevant? Are they just variants of unknown significance, and so forth? So starting with liquid biopsy, because this is a really hot topic now, and one of the reasons this is a hot topic is that tissue gets degraded, and even though our GI doctors and everybody in the room does a great job in tissue acquisition and taking great fine needle biopsies and core needle biopsies even, it sometimes is, it gets exhausted, and patients don't necessarily need to have another biopsy or don't want to have another biopsy. And the big question that has emerged in the last few years is the technology there to replace tumor testing with liquid biopsy testing? Liquid biopsy testing implies that you take a blood sample, and within that blood there is enough circulating tumor DNA that can be found and then can be determined whether or not patients have particular mutations or amplifications in certain genes. And there's also another variable, which is looking at cell-free DNA, which is a small amount of DNA which is distinct from actually circulating tumor cells. So cell-free DNA is present actually in circulation in many healthy people, has a short half-life, so you have to catch it at the right time. It has higher in many normal people as well, including pregnant women. And it's a mixture of what's called normal germline DNA and other circulating free DNA. And what we try to do is pick up the abnormal pieces of the cell-free DNA and then look at those areas to see if they have any hotspot genes. And then that will go ahead and provide us with the answer. So for many cancers, there is about a 90% concordance now between the prototype example is lung cancer, in which the biopsies that we do in lung cancer, like EGFR and ALK and things like that, there's about a 90% concordance rate in the ability to find these mutations in the serum. So what we're seeing gradually is shifts away from requiring tumor tissue biopsies and actually more clinical trials, and to some extent that's going to be followed by practice changing how we're going to be able to look at these assays in humans. So the next question is, and this is a very big question, because what we call NGS, or next generation sequencing, has exploded over the last 10 years or so, in which there are literally hundreds of companies that are now competing to send their assay, and they all have different claims about how sensitive or specific each one is at picking up specific mutations. And this is all over the map in terms of which is the right company to send to. By and large, what I would say is these companies all fundamentally do the same thing, which is look at the more frequent genetic alterations in any cancer, of which there's, of course, thousands. They provide a somewhat collated piece of data, which includes which mutations are present in that patient's genes, and then they refer you sometimes to whether or not those genes are considered actionable. The large majority, and we'll talk a little bit in specifics in a moment, but the large majority of mutations that we pick up on these next-generation sequence screens are not actionable. We find them and we're like, well, that's great that the patient has a mutation in ROS1 or in some other random gene, but it doesn't mean that intervening with a therapy will necessarily make a difference. So this is a big challenge in this field and has really changed the way oncologists are starting to think about it. Now, fundamentally, the reason why most oncologists will tell you, well, yeah, it's great to do next-generation sequencing is that with the explosion of these approved drugs, and now the majority of approved drugs in this day and age are not, of course, cytotoxic chemotherapy, but they're actually targeted therapies. They're actually looking to block a specific mutation or alteration in a specific gene. And you can see here on this list over the last 20 years, to some extent, most of these cancers have now exclusively developed drugs that are blocking specific mutations. So it's valuable and standard of care in some, and certainly in many GI cancers now, to get some next generation sequencing on these data, because we have to apply it towards how they're being treated. So in 2017, and this is even true in 2018, a good chunk of the drug approvals have specific molecular targets. I've just listed some of these here that were approved in the last few years. There's, of course, a whole separate group of drugs called immunotherapy, which are drugs that are attempting to stimulate the immune system to attack cancers. Foreign, these are, I'm sure many of you have heard of these drugs, PD-1 inhibitors or checkpoint inhibitors, and these are also now becoming approved in GI cancers. But there's a whole host of other drugs which are approved for specific mutations in the patient's cancer, and so therefore this is why we by and large insist that at least some base genetic sequencing be done on every patient now with GI tract cancers. So this really, in October of 2017, we had a landmark moment in oncology in many ways, because and GI cancer really led the way here, because it was microsatellite unstable GI cancer, MSI, that led to the first FDA approval of a cancer drug that was not based on where the tumor started, but rather the specific mutation. And the approval by the FDA, and this was I'd say revolutionary in many ways, was in all patients with MSI high cancer, regardless, of course the majority of them are GI cancers, but some are not, endometrial, ovarian, etc., even GBM. These drugs are now approved. These are immunotherapy drugs. Pembrolizumab, nivolumab are the two drugs, but they're approved for patients with MSI high cancers, regardless of where the tumor started. And this was a sort of landmark moment in many ways, and this has quickly been followed by another one, actually. The second, what we call agnostic of cancer site FDA approval, took place only 3 months ago, which is a much rarer thing called NTRK fusions. And NTRK fusions are actually seen extremely rare, but about 1% of lung cancer, 1% of colon cancer, 0.5% of gastric cancer, and so on. So we are seeing more and more, the expectation is more and more drug approvals will be based on tumor agnostic information as opposed to where the malignancy started. So let's talk about MSI, because MSI is the big thing that over the last maybe 5 years ago, it was only academic to know what a person's mismatch repair status was in GI oncology, but now it's become very practical. And it's practical, as I've mentioned, because of these drugs approvals and also because of prognostic information. And we regard, and I'm sure the GI community agrees with this more or less, but the suggestion is that there's very good correlation between immunohistochemical stains of the mismatch repair proteins, of the 4 mismatch repair proteins, which are MLH1, MSH2, MSH6, and PMS2, with corresponding microsatellite instability as would be tested in PCR. So by and large, if a patient has a loss in one of these proteins and a that can be measured simply by immunohistochemistry, which takes 5 minutes to do, and the pathologists are well trained to do. That is sufficient for us to confirm a diagnosis of microsatellite instability, and that is sufficient to now give the patient one of these immunotherapy drugs, which are incredibly effective for patients with this group of cancers. So many institutions, and ourselves included, have set up algorithms by how to do this. And here's just a basic schema that we use, which is similar to many other institutions, at looking first as a screening tool at all of the proteins, all 4 proteins by IHC, and then determining based on that whether a patient has true microsatellite instability or needs to be confirmed by PCR, which is rare, and whether or not a patient needs to be referred to genetics if there is obviously a suspicion of underlying Lynch syndrome, or if this is just a case of sporadic MSI. So many institutions have set up this kind of reflex pathological system, which allows us to be a little quicker at determining right away whether a patient would be a candidate for these drugs. So I'm going to go through a few individual cancers and explain why this has changed the way we think about it. So to start with gastric cancer, we'll start from the top, and gastric and esophageal. So when the diagnosis is made of an esophageal or gastric cancer, we know that the tumor can start anywhere, obviously, from the distal esophagus or proximal esophagus, but speaking just the distal esophagus and G-junction, all the way through into the body of the stomach and into the pylorus. And we know that right away, when a patient is diagnosed, we for now, as of 2019, with metastatic disease or locally advanced disease, we treat the patients with chemotherapy primarily, which consists of drugs like FOLFOX, platinum 5-FU, or if they have HER2, and those patients, that's an example of a approved genetic alteration, specifically in about 15% of gastric cancer. So that's why when you see the biopsies, we'll always say, okay, we need HER2. And those patients are treated with a drug called trastuzumab or Herceptin with chemotherapy. But this has changed dramatically, and in the stomach in particular, there is recognition, as we all know, that tumors from all over the world and from all areas within the gastric cancer have very different molecular landscapes. And so that the gastric cancer that arises in the United States from a GE junction, which is primarily the majority of our tumors, our proximal stomach, are very different on the molecular level from the tumors that arise in the body of the stomach. There's a whole different genetic phenotype that is extremely different, with different oncogenes and different tumor suppressor genes, different rates of microsatellite instability, rates of smaller things like FGFR, rates of EBV virus, and so forth and so on. So this field has become a prototype. Gastric cancer is probably one of the most heterogeneous cancers in this way. And so we're trying now to do every patient at our institution, every patient, when they have a diagnosis of gastric or esophageal cancer, has a NGS sequencing done to pick out these little ones, not the HER2, not the 10 to 15% for which we have a drug, but rather the 1 or 2% of mutational frequencies that can then determine whether there's another drug on the way. So the next GI cancer, just briefly, is, and I specifically left out colorectal cancer because colorectal cancer is, we all know that MSI has these drugs now approved, and we're trying to move beyond that at this point, but trying to look at some of the rarer cancers. Now, cholangiocarcinoma, we all know, is also a very heterogeneous disease that is distinct from where it started, whether it was intrahepatic, extrahepatic, and also very different in etiology. Globally, there's of course very different risk factors like flukes than there are in the Western world, where it's a more perhaps metabolic disease and metabolic risks. But the disease is very different depending on where it starts in the liver, whether it's intrahepatic cholangio, extrahepatic cholangio, gallbladder cancer. There is a different group of genetic mutations in each one of them, and again, different implications on how to treat it. So because it's both clinically heterogeneous and also has different risk factors, it also has different ways in which we go about treating it, whether it's chemoradiation or chemotherapy. And what we decided to do a number of years ago, and this I'll just show our data from this very recently that was just presented at an international meeting, is we decided to take advantage of the fact that we live in Los Angeles and we have many of these GI tract malignancies, and in particular liver cancer, which is a very relatively uncommon disease in the United States, but much more common in Los Angeles because of our large Asian population and large Latino population. So we tried to do what's called a basket trial, and I'll explain in a minute what that is. Many of you may know there's two big trial groups in oncology that are being done in an effort to develop drugs faster rather than enrolling 200 patients in a study and looking for a small statistically significant difference. The field has moved on to these, and based on this next generation sequence strategy has moved on to these different groups. One is called an umbrella study, in which you test the impact of different drugs on several mutations in a specific cancer. So you take, let's say, cholangiocarcinoma as an example, and if a patient has a HER2 mutation, they get drug X. If they have a BRAF mutation, they get drug Y. If they have an FGFR, they get drug Z, and so forth and so on. And that's one group of trials. And then there's something called a basket trial, which is what the microsatellite instability story was, which tested everybody, regardless of a specific drug on a specific mutation, regardless of the underlying malignancy. And basket trials, like the MSI one, are becoming very popular now because they're leading, with the openness of the FDA to allow drug approvals in this way, they're leading to more and more approvals. So we launched a basket trial, a global trial, in which we looked at any patients who have a BRAF V600E mutation. And BRAF V600E is one of the most common oncogenes in cancer, probably third most common after probably KRAS and maybe one more. BRAF V600E, which is very common in a disease like melanoma, for which drugs are already approved, not uncommon in a disease like lung cancer, for where drugs are already approved. And we looked at 9 different cancers, all of whom had very rare cancers that in the United States we would never be able to do large trials. We would never get these drugs approved and out there for folks if they, as a single standalone entity. And we looked at these individually, and all patients, we enrolled them only if they had a BRAF mutation. And this is very hard to do because some of the frequency of mutations in this disease is 5 to 10% of the entire cancer. So you have to screen thousands and thousands of patients with these NGS sequencing to find just a small group. But the FDA was accepting of this. And for example, where we took the lead at UCLA was in the biliary tract cohort, because as I mentioned, we have a lot of patients, and we looked at BRAF mutated biliary tract cancer, which included intrahepatic and extrahepatic cholangio, and enrolled all patients with these 2 drugs, dabrafenib and trametinib, one of whom is a BRAF mutation inhibitor, one of them is a MEK inhibitor, which is just downstream. And we just wanted to look at, did the drugs work in patients with metastatic disease or locally advanced disease who had already been through, as I'll mention, chemotherapy. And we enrolled, as you could see, it took us about 4 years, and globally we screened 557 patients for this BRAF mutation, and we only found 49, of which 35 were eligible to be enrolled. So just to give you an example, that's 5 to 8% of cholangiocarcinoma globally. So not a big number, but as you'll see in a minute, a very relevant number for those patients that enrolled. And you can see here some of the other cancers that were enrolled in this study as well. So the results were very exciting because we've never seen these this is a waterfall plot, of course, showing how the tumors decreased, and these were all patients who had progressed on chemotherapy. Many of these patients were being planned for hospice, and they came in and they had this BRAF mutation, and the large majority of these patients, very large majority of these tumors went down and shrunk, and many of these patients, what is probably even more exciting, is that many of these patients are still on this combination 2 years later or 3 years later, which indicates that the oncogene was truly driving the cancer growth in that segment of patients. So, and here's, didn't come out so well in the pictures, but here you could see is one of our patients at UCLA who's been on the study for now about 2 years, or almost going to be 2 years, who's had a dramatic decrease in the size of the tumor. And all this is with 2 pills because she has this unique genetic alteration. So this is all interesting and relevant for the 5 to 7% of patients that have this mutation, but the FDA will accept this, and in fact this is being submitted hopefully for approval by the FDA shortly. So the classical example where genomic characterization or next-generation sequencing doesn't matter much as pancreatic cancer, and that's probably the biggest struggle. Pancreatic cancer is an example of a disease where, by and large, there are very classical and typical genetic profiles. So when you sequence a tumor of pancreatic cancer, you send it for one of these fancy tests, you almost always get the same thing, which is a KRAS mutation that occurs in 96% of patients, P53, which is lost in a good chunk of patients, and P16, which is also lost in about 40 to 50% of patients. So you see a very typical and fairly unactionable mutation profile in pancreatic cancer, unfortunately. And there's probably lots of reasons for that. But there have been some new studies, and this is where perhaps we are seeing some changes. There have been some new studies in the last few years that have shown that the rate of actionable mutations is increasing. The more we test patients with pancreatic cancer for these next-generation sequencing studies, we are finding that about 20% of them may have what's called an actionable mutation. First of all, there's a group of 5 to 10% that don't have a KRAS mutation, which have a KRAS mutation is our holy grail in oncology and is considered a non-druggable target. But there is the other 5 to 10% of patients don't have a KRAS mutation. They themselves are subject to a number of drugs. And there is a group of patients with DNA repair deficiency mechanisms. The prototype example is BRCA, BRCA, which is probably relevant in about 8% of pancreatic cancer, and then there's a few other percent of patients that have a similar, whether it's POLO1 or BARD1 or BRCA2, similar DNA repair deficiency mechanisms that occur within the tumor that may make them sensitive to these drugs called PARP inhibitors. So this is changing very, very slowly, in which historically we would say, oh, there's no value in doing next-generation sequencing in a disease like pancreatic cancer. It always has a very similar prototype, and that's still, unfortunately, true. I will say that what we are seeing now is changes in the way that is occurring, and as more data emerges, we expect that that'll change in the future. So to summarize from top, gastric cancer and esophageal cancer is perhaps the most relevant because it has the most number of targetable, actionable mutations. So we are routinely doing next-generation sequencing in every patient with that. Cholangiocarcinoma is one of the new ones. I presented data here today. Pancreatic cancer is still a ways behind in that regard. And colorectal cancer now is probably the best example of why we should do it, because we have 10 to 15% of patients with microsatellite instability, which can be easily tested by mismatch repair protein, by IHC. We have another group of patients with BRAF mutations, and so forth and so on. So at UCLA, for example, a patient walks in the door and has a diagnosis of colon cancer. We have a reflex group of 30 genes that is checked internally by an internal panel by our pathology department, can tell us right away whether it has one of the mutations within that genes, which includes MSI. And if you want to go beyond that, you have to send it to one of these companies, which used to be about $3,000 and take a month, now is back in 2 weeks and costs usually about half the price, of which more or less 20% is submitted to the patient that they have to pay. So a patient will have to sometimes pay $600 for one of these tests, and the majority of it is now covered by insurance. So in conclusion, GI cancers are perhaps in many ways the prototype example, perhaps after lung cancer, of where we are seeing progress in the way we genetically characterize these tumors into different molecular phenotypes. The mainstay, and this is obvious to all of us who see these patients, is still chemotherapy. These drugs are still, with rare exception, not used in what's called the frontline setting, are used later on, and that's the way it is for now. I think the future will, and all the studies that we're doing are incorporating newer assays like liquid biopsies, which are a little bit easier to get fast results on and have been validated in many patients. And immunotherapy has really, as a group, has changed the way we treat cancer, and except for MSI, they're not approved yet for any GI cancers, but the hope is that many of these combination strategies that many people are involved with will be changing that. So I'll thank you very much for your attention and take any questions.
Zev, I have a couple of questions for you. One is, you talk a lot about the promise of a liquid biopsy, but we also sometimes are told about tumor microenvironment and the need for architecture and getting core biopsies for pancreas cancer and so forth. So do you see that a liquid biopsy may ultimately be beneficial for all types of tumors, or do you think some are still going to require sort of a combination approach or actually architecture?
I mean, I don't think liquid biopsies are going to change. I mean, they're not going to replace a traditional biopsy anytime soon in the classical sense of making a diagnosis and looking at architecture. I think what is being incorporated is in patients in whom there's no archived tissue available, advanced cancer patients who we don't necessarily want to put through another biopsy because we want to see if they have a specific mutation. I think the research is gradually moving in the direction that in some patients you can replace that, but that's not true for the patients you're referring to earlier on and establishing a diagnosis.
Second question actually sort of implies a parallel to another disease state. So in IBD, there are over 200 genes associated with the disease. A typical patient may have 3 to 10 associated gene variants affecting a variety of molecular pathways. Do you see that the approach that you're using in oncology may ultimately be applied to other aspects of medicine that don't involve cancer?
Yeah, I mean, that's a very interesting question, and I think that, sometimes the unexpected results of all, and Dr. Meyer talked about that too, the unexpected results of what comes up on these studies opens the door to new things. For example, in the cancer world, when we check a full generation sequencing study and we find an obscure mutation that has nothing to do with what we think is related to the cancer, it leads to this genetic evaluation, which sometimes finds very unexpected results. So I think, obviously, this is always going to be intertwined, and just like in IBD, they have a lot of mutations that people aren't sure exactly what they mean. We have the same thing in most cancers. So it is a very interesting. We've gone down the rabbit hole, and many of these patients lately have these very unexpected genomic findings, and it has implications for the entire family because they end up getting sent to genetics counselor, which picks up a germline mutation in a random gene, which never would have been found because they don't have a family history and they don't have a classical phenotype of, let's say, some familial syndrome, but yet the tumor has this mutation, and how did that get there, and what does that mean? And so when we found it, and I can think of several recent examples in the last few months where it has happened, we send the patients to genetics counselor and boom, they have the germline mutation. We never would have thought of that. It wouldn't have been on our radar because it's not the classical way we would have thought about it, but yet the whole family now gets screened for CDH1 mutation or whatever random thing came up on the tumor biopsy. So you bet.
Additional question.
Yeah, so we've had a lot of experience with all of these companies, and so within our own UCLA system, we do just a basic hotspot ion torrent analysis on 30 or 40 genes. Then the problem is if you want to find the obscure ones, like we're not going to pick up things like NTRK fusion, which is, as I mentioned, just has now one drug approved and is 1% of a lot of cancers, then you have to send it out to farm it out to one of these companies. I'd say the biggest company out there you probably heard of is Foundation Medicine. They're probably the most established company in which they've got a streamlined system they work with almost every pathology department in the country to get the tissue out quickly and to try to get a report in. But I find that many of these companies are very similar in the products that they deliver. There are nuanced differences between them, of course, but the large majority of them are testing for the same panel of genes, and the way in which they give the data back is very, very similar. I think economically it's certainly more efficient, and for the common genes, things like KRAS and BRAF and all of these very common ones, it's just as reliable as one of these fancy NGS, Illumina-based sequencing techniques. I agree with you, yeah.